Kia ora, I'm Dr Helen Fulcher and I'm speaking with Dr Alistair Dunn, a Northland general practitioner and addiction medicine specialist. Today we're speaking on the problem with opioids. So Alistair, opioids are prescribed in New Zealand for acute and chronic pain. However, they have a clear addictive potential. What makes them so addictive?
Well, I guess what makes any substance addictive? Something about them people find rather moreish. And with opiates, they act at mu receptors, several different types, which are why they can relieve pain. But in particular, the mu receptor is where we think it's linked to feelings of pleasure and reward. And the end result is a release of dopamine in our pleasurable frontal lobes. And we know from research that there's a dopaminergic reward pathway. And this is the pathway that's lit up when people use opiates or opioids. It's also lit up by numerous other substances which become addictive. With repetitive use, this pathway becomes quite ingrained. The neurons that fire together wire together, and this habit becomes very hard to stop. The usual brakes controls over use are lost, and the drive to continuing to use develops into an addiction.
So we've mentioned these medicines are really great for treating pain. If we aren't going to use them because of this problem, what else could we use instead?
Well, just to clarify, I mean, they're still great painkillers. I mean, if I've got acute pain and ED, I want an opiate, thank you very much. But we need to make a distinction between acute pain and short-term prescribing and chronic pain. And it's the treatment of chronic non-malignant pain with opioids that I think has the great risk for addictive consequences. In the case of long-term pain management, we need to look at non-opiate medications, but even more importantly in the long term, I think non-pharmacological management of chronic pain. And this is where we like to try and involve multidisciplinary pain teams, including occupational therapists, physios, psychologists and the like. And a lot of their work helps patients come to an understanding about the situation they find themselves in. Patients typically have a great difficulty adjusting and accepting this new body that they've got, this damaged body that can't do the things they used to do. And that's also part of a grief reaction because they've lost the ability to do those things. And often it can mean losing their role as a provider in the family. So there's huge issues of guilt and frustration that they've got to work through. One thing that patients often have is an expectation that the doctor's going to cure this problem. After all, they come in with a strep throat, we can cure it with some penicillin, but they come in with a chronic pain problem, we're not really going to be able to cure it. So I encourage GPs to say to the patient, I can't cure your pain problem, and it's going to come as a shock to them. But I then say, well, I can't cure your diabetes either, but I can help patients with diabetes learn to manage their diabetes better. And that's what we can help with chronic pain patients. Help them manage their chronic pain so they still can do the things they want to in life and get some value and meaning out of it. And when we're looking at goals of treatment, pain teams will often try and develop functional goals for patients to achieve so that they can do the things that's important to them. Rather than just focus on how much pain am I having today, it's more about what did you manage to do today.
So there are lots of tips there for changing the way we think about treating someone's pain and not necessarily reaching for the opioids prescription. What are the red flags that if we are considering then to prescribe opioids to someone, what are the red flags we should be looking for? Or if someone has come in asking for a repeat prescription, they're already taking opioids, what other things should we be thinking about?
There are some certain risk factors or red flags we need to look out for, and clearly if a patient has a past history of alcohol and drug problems, they're going to be at greater risk of developing an addiction problem with their opiate. And it doesn't matter whether the past addiction was to an opiate or to some other substance, because all the substances turn on the same addictive pathway. But it's not just a personal history of addiction that's important. Even a family history of alcohol and drug problems is significant. And in one generation it might have been alcohol, and the next generation it could be opiates. We know there's a strong genetic or hereditary component to addictive risk. Finally, in some patients with injecting opiate addiction, hepatitis C is common amongst injecting drug users. So if a patient has a past history of hepatitis C, that can be an important clue that they've injected drugs at some time in their life. And it may have been only a few times a long time ago. That's not something patients necessarily feel comfortable disclosing, and they may prefer to tell you it was due to a tattoo they got in Thailand years ago. And that's fair enough. I wouldn't challenge patients about that. But the reality is, in my field of work, 80% of the patients that I see with hepatitis C got it through injecting.
So Alistair, thanks for those red flags. If someone comes in and doesn't have any of those, we've tried lots of things for their pain, they don't seem to be working right now, we'd quite like to start prescribing some opioids because we think they'd be effective for them. Is that okay?
Well, I think opiates are always okay in the short term, but again, with long term, I'd still have concerns. Even if someone doesn't have any apparent risk factors, they still have the potential to come unstuck with an opiate. And evidence abounds from the United States where they've found risks of overdose and death from prescribed opioids occurred amongst a large population of people with no prior history of addiction problems. They'd never used an illicit substance in their life. The only opiate they used was that which was legally obtained through a doctor's prescription. So we need to adopt an approach of universal precautions, essentially, so that anybody that comes in the door is at risk of developing problems with the opiates we're about to prescribe.
So ideally we don't prescribe them. But if we are in a situation where we're either refilling a prescription or there is a prescription happening for opioids, what tips do you have about prescribing these?
Sure, and we all of course have inherited patients from someone else and we're stuck with a long-term prescription. But I do think there are some safeguards we can put in place. And the number one suggestion I like to make is tight, close dispensing arrangements. And I think a weekly dispensing arrangement is a really good idea if you've got any concerns whatsoever. If the medication is picked up on the same day each week, it becomes readily apparent if the person's picking it up early, and the chemist or the doctor will pick that up quite quickly. I think regular review is important as well, rather than just having the prescriptions repeated by telephone order without any review. These patients on controlled drugs need to come in for regular review to check that the medication's working, that it's still indicated, and explore some of the other non-opiate options that are there for management of chronic pain. I think it's important to clarify what your maximum dose is going to be with the opiate. And we do this commonly with other medications. We have a set dose, and if we're not getting a good effect, we abandon that medication. So with opiates, we need to be quite clear as to how far you're going to increase this, and there's a certain point at which you get no further benefit. And with morphine in particular, a daily total dose of 100 milligrams a day would be the absolute maximum. A lot of people these days are thinking more in terms of maybe 60 milligrams a day. If you're not getting good effect by then, there's no more bang for your buck to keep increasing it. Occasionally, in perhaps more severe cases where people have really developed problems with their opiate use, having a contract in place, these are often used by pain services and you can Google them quite easily to find them. Having a contract that the patient signs that clearly specifies some of the dangers of opiate medication, clarifies the dispensing arrangements, the dose limit and that kind of thing, and regular review dates is a good idea of illustrating to the patient why you take this medication so seriously. They may be unaware of the pitfalls of opiate use and its dangers. So I think a contract helps clarify and illustrate those for the patient. Sometimes urine drug screen testing is useful. That's a difficult thing to do in general practice. I mean, working in the methadone service, I check urine drug screens on a weekly basis with lots of patients, and I'm comfortable doing that. But I find as a GP, I'm a lot less comfortable arranging a urine drug screen because it's contrary to the usual relationship you have with the patient. You're basically saying you don't quite believe what they're disclosing to you. But nonetheless, on occasions that I have done a urine drug screen, it's been very helpful. So although it's difficult to ask a patient in general practice to provide a urine sample, it can provide good information. If, for example, it comes up with non-prescribed benzodiazepines or methamphetamine, this clearly looks like a polydrug use situation, and those substances have no part to play in pain management and that sort of case needs a referral to an addiction service.
So Alistair, you've touched on how sometimes the conversations we have with our patients around this prescription can become quite awkward. What are the things that we need to be talking to our patients about while we're talking about opioids?
Well, certainly we need to emphasise that it's a potentially dangerous medication. It can cause overdose, respiratory depression, especially if it's combined with alcohol, benzodiazepines or other CNS depressants. And in addition to that, people are unaware of its risks, so it can be commonly left in the cupboard if it's not all used up, and a well-meaning auntie might give some oxycodone to their nephew who's a fisherman because he's got a bad back. She might think oxycodone sounds a bit like codeine, doesn't sound too dangerous. She won't know it's more akin to heroin. So safe storage and being aware of the risks of diversion for resale or injection is important. And those sometimes are things that are outlined in a contract.
Okay, Alistair, if we have a patient come in who's taking opioids and we think may have developed a substance use disorder, what can we do? What do we do about it in primary care?
I think definitely the thing to do is refer them for an assessment at the Alcohol and Drug Service. And if they concur that the person's got a significant substance use disorder or addiction essentially, the best treatment for opiate addiction is OST, and that stands for opioid substitution treatment. And in the old days, people will be familiar with patients on methadone programs, and this is exactly the same treatment. Methadone programs are a form of opioid substitution treatment. We've had to change the name because now there's a second medication we can use, and that medication is buprenorphine. It's available as a medication called Suboxone. So now to treat someone with an opiate addiction, we've got the option of methadone or Suboxone. There are two kinds of opiates, so the umbrella term is opioid substitution treatment. It's a treatment that's been around since the 60s, and it's been incredibly well researched, it's well proven, and it essentially provides a regular daily dose of opioid so to satisfy the person's cravings and keep them stable and avoiding withdrawals. But it goes beyond the physiological treatment. By having a regular daily dose provided, the person is no longer needing to run around and get extra opiates, and they can start to stabilise their life in other domains so that they maybe can get a job and restore family ties and that sort of thing. And it's really rewarding work to see how people progress in their recovery. And I think GPs can have an important role to play with these patients because once they've reached stability, services are very keen to transfer them back to a GP. And we do struggle at times with reluctance from GPs to take these patients on, but it's a really rewarding work.
So OST sounds like a good form of treatment. Does it actually cure the patient's addiction or substance use problem?
Well, certainly it's a bit like giving a drink of alcohol to an alcoholic. We are giving opiates to people with an opiate addiction. So in some ways we don't cure the addiction at all. We're feeding it with our own prescribed medication. But the key thing is it's in a regular supervised way. Patients on opioid substitution treatment have very close monitoring in their early days and frequent checkups with the chemist and with their caseworkers and their doctor. As the patient progresses in their recovery, illicit substance use diminishes, and usually they'll reduce their injecting as well. And that's a key goal of treatment because of the risk of hepatitis C transmission through injections.
So Alistair, are there any risks to using OST, methadone or Suboxone?
Definitely. I mean, methadone is an incredibly powerful opioid. A normal dose for a patient on a methadone program would be in the order of 75 milligrams. And a fatal dose for URI, assuming you're opiate naive, is 40 milligrams. And these people are taking this kind of dose on a daily basis. And Suboxone, while safer, still has risks, especially when combined with other CNS depressants. So that's why there are very strict conditions and regulations around methadone programs requiring the patient to go frequently to the chemist. There's got to be safe storage of the medication because there are risks of it being people doubling their doses or injecting or diverting it for sale.
So Alistair, there are lots of benefits and there are some risks with using OST. Do patients ever come off OST? How do they finish?
Well, that's a commonly asked question, and certainly a lot of people stay on OST a long time. And we have a really aging population of people on the program now going into their 60s. And I'm waiting for our first patient to be in a rest home and still being on OST. But it doesn't worry me. The key finding is that when people come off opiates, there is a high risk of relapse. And if you think about the stability someone might have achieved in their life through treatment, they're putting a lot at jeopardy if they come off and relapse into especially illegal drug use. So maintaining them on the medication is, from a harm reduction point of view, the best thing to do, because they're making good gains in their life. So we have no set preconceptions about how long they're going to need the treatment. It's as long as they need it, as long as they want it.
So Alistair, you've talked about Suboxone. Can you describe exactly what it is and how it works for us?
Sure, it's a relatively new medication for us, and Suboxone is the brand name for the medication. It's the only formulation available, so that's why we tend to use the brand name. I know we should in the Goodfellow unit use generics at all time, but it actually consists of buprenorphine and naloxone, which is Narcan. So the idea of the addition of the naloxone is that when the Suboxone is taken sublingually, the naloxone is inert. It's simply passed through the body and not absorbed, so it has no effect on the opioid effects of the buprenorphine, which is an opiate agonist. But if the Suboxone was to be taken home and injected, the thinking is that the intravenous parenteral route of the naloxone would, being an opiate antagonist, promptly displace all the opiates, triggering a very unpleasant and hopefully aversive reaction, an abstinence reaction immediately. And so this sort of deterrent feature was important in getting this drug accepted in places with the FDA, for example. So in other countries, there's both pure buprenorphine and buprenorphine naloxone. In New Zealand, we just have the combination product called Suboxone. There are some important differences between it and methadone. It's not quite as strong. It's certainly safer. There's a ceiling effect to its respiratory depression. So it's pretty hard to overdose on Suboxone alone, and that's a really good feature. It's incredibly long acting, so people don't have to go to collect it from the chemist so often. And because there's less sedation, it's good for patients that want to be clear-headed and cognitively functioning well. And so when you've got high-functioning patients, it's useful. And I think there's an evolving niche role for Suboxone for people who have developed prescription opioid dependence, who might be quite high-functioning and they don't want the heavy sedation of methadone. The Suboxone seems to fit perfectly for those kind of people.
So it sounds like a really great treatment option. What are there side effects? What are the side effects of it?
Well, Suboxone, being an opiate, has similar side effects to methadone, and like all opiates, they can cause constipation and dry mouth, which can in long-term use lead to dental problems. But apart from that, Suboxone is actually pretty devoid of major side effects. Methadone, on the other hand, has a few more hooks in it. It can cause neuroendocrine problems. Hypogonadism in males can lead to reduced sex life, but also actually osteoporosis, especially with a lot of the clients who also smoke. And another key thing to think about with methadone is QT prolongation. And that's especially a risk when people are on other medications that prolong QT. And I'm thinking of antidepressants or antipsychotics, which these patients are often on our programs.
So Alistair, we've established there is a problem with opioids, and opioid prescribing can be fraught with difficulty. How do primary healthcare practitioners learn more about OST treatment and how to manage opioid prescribing?
Well, I'd love GPs to become more involved with OST treatment. We have patients on our program who are very stable and we're itching to transfer them out, and there's an understandable reluctance by GPs to take these patients on. But I'd like to reassure people out there, we do try and select really stable patients, and I think they can be very rewarding. And they have complex comorbid problems in their health that really need a good GP and primary care to address. The mortality rates of our patients is really high considering their young age, and it's not from drug use and overdose, it's from health problems like liver disease and heart disease that they need a good GP for. In terms of learning more about it, there's a really good training module from Maturaki about opiate substitution treatment. And I'd like to encourage people to get to know the local docs in their alcohol and drug service. And any time it's good to ring them for advice about any patients you think that are coming unstuck with their medication.
Okay, Alistair, so do you have any key take-home messages for the health professionals listening today around opioid prescribing and how we should be looking at OSD treatment?
Well, I think always take care with prescribing opiates. They can be easy to start but hard to stop. And if you think someone's developing a problem, try and have a conversation with them about it. And above all, liaise with your local A&D service.